welcome to the HTAi Interest Group webinar, Challenges of Assessing Digital Technologies in LMICs. As we wait a few moments for further participants to join, I will share a few slides with you about the society. HTAi is the only global society championing equitable, responsive, and cutting-edge health technology assessment. Our members are a worldwide community of multidisciplinary advisors, academics, scientists, and professionals. HTAi membership holds many benefits, including HTAi's premier events and a specialized interest group, free online access to the International Journal of Technology Assessment in Healthcare, HTAi resources and news, including e-newsletter, bulletins, and international development in HTAi. For more information on membership benefits, visit our webpage on our website. HTAi interest groups are open to all members of HTAi. They act as a forum for HTAi members to network, exchange information, and collaborate on projects of mutual interest throughout the year. Visit the HTAi website for more information on our interest groups. The next HTAi 2025 annual meeting will take place in Buenos Aires, Argentina from June 14th to 18th. You can find more information on the event website. We kindly ask participants to remain muted until invited to ask questions. Alternatively, please submit any question through the Q&A function of the Zoom meeting platform. Thank you again for joining us today. I will now hand over to the chair of the webinar for introducing the webinar topic and formally welcome the participant and the speaker. Thank you very much.
Thank you, Nicola. Good morning, good afternoon, good evening, everyone. My name is Yanga Nokepei, and I will be chairing today's session. So just give me a few minutes to share my slides. Just to give you a brief introduction to our interest group, the Developing Countries Interest Group. The interest group provides a platform for members from developing countries to share their experiences, to discuss the needs, the challenges and solutions, and also to support activities that are related to building capacity in HTAi in LMICs. The DC, let me try to hide this. The interest group is chaired by Jani and Ezra, and it's supported by 10 steering committee members, as well as Marilia, who is our technical officer. Today we'll be discussing the challenges of assessing digital health technologies in LMICs. We are aware that over the last decades, several LMICs have improved their healthcare systems to include digital health. However, the adoption of digital health technologies in these healthcare systems is fragmented and is faced with several challenges, such as the lack of regulations, the poor reimbursement guidelines, the non-uniformity in quantifying the value of DHTs to inform decision makers. So our webinar today, we will be discussing the challenges in capturing global and local factors associated with digital health technologies using current approaches in HTAi. So I'm going to hand over to our first speaker for today, who will be Rossella, to take us through her presentation.
Thank you very much.
Stop sharing.
Okay, and I'll start sharing. Let's see. I hope you can see my presentation, my slides. Thank you very much to have included me in this very interesting webinar. I'm Rossella di Bidino. I'm working at the Gemelli Teaching Hospital in Rome in the Department of Health Technologies. And I'm also responsible of the unit on health technology assessment for AI at Artemis, a graduate school in health economics, in health economics, and management in healthcare. But today I'm here with other two hats. First of all, I'm here because I co-chairing the HTAi interest group on hospital-based HTAi, and because I'm one of the participants to the project called EDiHTA. Our hospital-based HTAi interest group counts on more 200 members. It's co-chaired by me and my colleague EDiHTA from Poland, and we can count on the valuable support of our technical officer, Monica Kugas. Also, our interest group has a steering committee. We have just 5 members. Maybe you already know some of them. They are Dr. Amerigo Cicchetti from Italy, Professor Laura San Pietro Colon from Spain, Professor Christian Kildon from Denmark, Dr. Marco Marchetti from Instance, and finally, Marina von Pinocchi from Switzerland. Our interest group is conducting many projects. In a few minutes, I show you the result of the survey that we conducted in 2023. But we are also a project focused on low, medium income countries. For instance, this year we are working with India experts in order to understand which can be the potential role of HTAi in India. So let's move to the result of the survey. We conducted it last year. The survey was open to hospitals where HTAi is performed, but also to people from hospitals where HTAi is performed, and we collected responses also from members of HTAi agency and Ministry of Health. Indeed, our aim was to understand which is the current scenario for hospital-based HTAi, which is the perception by all stakeholders of this kind of activity. In just 3-4 months, we were able to collect 87 responses. Almost half of them were from hospitals where HTAi was performed, and we were able to collect responses from 28 countries and to cover on all continents. Some countries were more represented. We have more than 10 responses both from Italy, Poland, and Brazil. What emerged is that the HTAi is usually performed in hospital with of big dimension, with at least 500 beds. The HTAi unit were established in the almost 44% of the cases in the previous decades, between 2020 and 2010 and 2020. The aim of this unit was to support both the clinical and the managerial decision-making processes. Here you can see also the kind of technologies that are usually assessed at hospital level. It's quite common the assessment of medical devices, but as you can see, in more than 1/3 of the hospital are already assessed digital health intervention. I mentioned you that I'm here also with another hat. I'm participating to the EDiHTA. EDiHTA is a European-funded project finalized to the development of the first European digital health technology assessment framework. What we aim to produce in 4 years from now is a flexible fit-for-purpose HTAi framework that is applicable to all kinds of digital health technologies. So it will be applicable, we hope, to mobile app, telemedicine, artificial intelligence, virtual reality, and so on. What we aim is just to adapt and enrich the current HTAi framework that we have for medical devices and drugs in order to capture all the peculiarities of each kind of digital health technologies. And what we aim is to provide a framework applicable along all the life cycle, so since the first step of development till the disinvestment stage. And ideally, the framework will be applicable at different levels, at national, regional, but also hospital level. As you can see, we can count on a very good budget of almost 8 million euros, and we are a consortium composed by 16 partners, all based in Europe. They come from 10 different countries, and they are HTAi agencies, hospital. We have also patients organization. We can count also on some notified bodies and global quality assurance bodies. There is also the participation of the European Institute for Technologies, EIT, and then there is the European Patient Forum and the European Health Management Associations. On your right, you can see also the name. There is a Catholic university that coordinates the consortium. There is a roundabout university from the Netherlands, the NICE, the Norwegian Center for E-Health Research, and so on. But I think that it's best to see the faces of the people that are involved in. All these people are working to define the framework according to the 3 guiding principles that you can read on your left. That is, we aim to harmonize and enrich the existing HTAi framework. We want to co-create that framework together with not only HTAi experts, but also developers, patients, and regulatory bodies. And then we want to provide a framework that will be already tested on some real cases, on some real digital technologies adopted or in development at different levels of the healthcare system. Here is, you can see our methods. Obviously, we have started from an understanding of the current scenario in terms of regulations and policy, mainly at European level, but not only. Then we have identified our relevant stakeholders, and we are working on the definition of a common taxonomy in order to share a common language. Now we are in the phase of the identification of the all stakeholders' needs and requirements. Afterwards, we develop the framework, we pilot it, and then we put the framework in a digital format, pilot it again, and so on. I want to share with you the results of the interviews conducted with hospitals in order to understand their needs and requirements while assessing or implementing or even developing digital health solutions. We conducted 22 interviews with experts from 13 countries. The majority of experts were from Europe, but as you can see, we were able to involve also experts from North and South America and 1 expert from Kazakhstan. Our experts have covered different levels of the hierarchy. In the majority of cases, they were head of a unit, HTAi unit or clinical ward. We interview also director of department, C-level expert, and even 1 vice president. What emerged from our interview, that it emerged that the majority of experts, almost 70% of them, already assess or try to assess digital technologies. In almost all the cases, there wasn't an already defined hospital procedure for the assessment. What is happening is that the current procedure and HTAi framework are adapted case by cases. Then the involvement of the experts in the assessment were quite heterogeneous. It differs in relation to the stage of development of the technologies and on the step of the decision-making process in which the experts are involved. Here I want just to share you some of the main messages that we collected by experts. I just cited them. First of all, it emerged that we have to adopt a more holistic view. First of all, because digital health technologies never operates in isolation. And mobile app is not the same as a peer. We have to consider all the contexts in which the technologies is adopted and implemented. So we have to focus more our attention on the clinical pathway rather than on the single technologies. Then we have to consider the strategy at regional or hospital level, because the business strategy of the hospital won't be the same one of the developers. And we have to be aware of that when we are going to assess the technologies. And then we have to pay also attention to another important step. It's important not only to assess the digital technologies, but also to be able to reassess it in 2-3 years, given the pace of innovation and the evolution of the hospital needs. What emerged is that hospital and meso-level experts are asking for an HTAi framework that is multidimensional as any HTAi framework, multidisciplinary, flexible in order to be adaptable to the local level. It should be also adaptable to the specific kind of digital health technologies and of the local context. And then it must be transparent. Our expert identified one big issue present at the moment that is represented by the lack of high quality evidence. So that means that we are not able at the moment to evaluate as we desire the effectiveness and the impact of the digital technologies, because we cannot count at the moment of this kind of evidence. Our experts are asking for the framework, but also for validated guidelines. Guidelines, for instance, on how assess economic implication in the short and long term, on how involve all stakeholders, and on how define and measure clinical relevant outcomes. So, in conclusion, what we can learn from, and we learn from the EDiHTA project. What we learn is that we need a vision. We have to ask to experts, involve all stakeholders, and pilot test the HTAi framework and tools that we are developing for digital technologies. And I'm here also to ask you to share with us your needs and requirements in order to make more representative and consensus-based our work. Thank you very much for your attention.
Thank you so much, Rossella. I'm going to hand over to our next speaker, Daniel Opoku.
Yeah, thank you very much, and I appreciate being here. I would like to share my screen and proceed with introducing myself, but briefly and present. Please confirm if you could see my screen at the moment.
Yes.
Yeah, thank you. Please, do you still see my screen? Just double checking.
Yes,
Yeah.
it's okay.
Okay, thank you very much. So my presentation is taking a dive into the regulatory authorizations for digital health technologies in Africa. And this focuses more on some of the research activities and initiatives that we have started here in Ghana, but of course with relevance for the African continent or the region as we have it. Yeah, so I sit at the Kwame Nkrumah University of Science and Technology in Ghana, specifically in Kumasi, which is largely the forest belt of Ghana. But at the same time, I have a research scientist position at the Berlin University of Technology. And here at the Kwame Nkrumah University, when I had joined in 2020, we launched my research group called the eHealth Research Partner Group at the Kwame Nkrumah University of Science and Technology. And our aim is just simple, that we want to advance the utilization of evidence to inform health systems digitalization and innovation in Africa. For purposes of today's webinar, my agenda is for us to provide first an outlook of the emerging digital health technology industry with relevance to Africa, and then for us to discuss the regulatory needs for digital health technology, also with relevance in Africa. I know we are all expert. I will not bore you down with a definition, classic definition of what digital health technology is, because the earlier presenter, Rosalind, has already presented some ideas of these initiatives and the work also of the HTAi in this regard, except to emphasize, just referencing a point that the classification of digital health technologies is quite broad in perspectives and have been means different things to different countries at a certain point in time. And it is largely driven, as we found, by the scope of utilization of most of these digital technologies as we have it. And so you see, from mobile medical apps and through softwares that support clinical decisions of doctors, and all the way to artificial intelligence driving a revolution also in healthcare, all come under the broader definition of digital health. Well, normally I will show this slide, and it's it gives a pictorial evidence of the penetration of digital technologies. And to look at the huge jump or leap in adaptation or adoption of the use of digital technology interweaving in our everyday lives is what I wanted to demonstrate with this picture. And this was just the inauguration or installation or the announcement of two popes of the Roman Catholic Church. One in 2005 and then the other in 2013. And this is just demonstrating that in less than a decade, the rise of the use of mobile phones or mobile devices was very remarkable and massive. And this denote or demonstrate really the high penetration of digital technologies in our facets of life and the various fabric of our society. In Africa in particular, when you look at the cellular infrastructure a great potential and a great moving from 2G networks to 4G networks. And we see the quick uptake of updated versions of technologies in our part of the world. And I have other slides where I compare the growth of pattern of cellular infrastructure and the uptake of mobile phone usage versus access to potable drinking water. And I stated quite profoundly that people living in Africa have access to cellular technologies or mobile phones more than they have to, for example, potable drinking water. And this is really the level of penetration that we also have in this part of the continent. And I am happy also to show this as a recent event on the 4th of November when Ghana's telecommunication minister had launched the 5G network. And the expression that, or the way they describe the relevance of 5G network to them is the fact that 5G network is going to drive the digital economy and inclusive growth also in the bigger economy. And this is the kind of tool or the kind of relevance or importance that digital technologies have become, and the critical role they play in also in the bigger enterprise of the economy. Now, still providing an outlook of the digital health industry in Africa, just a few of some of the potentials or utilization of digital technologies for health in Africa is what I want to show you. And one of this was in Ghana, the largest healthcare provider called the Ghana Health Service, which is responsible for primary and secondary healthcare service delivery in the country. He launched just a simple USSD short code for safe motherhood. And the whole idea was that they want to, within the 9 months of pregnancy, where they wanted to check, follow up, provide pregnant women with information, adequate information to be able to take care of their pregnancy or the baby unborn and themselves. And a simple tool as a follow-up, a health educational campaign where they call mothers, or you can call to ask for information about your pregnancy, was is one of the simple utilization of such mobile technology. And this is just what this intervention really does, where you subscribe to it, and then you receive some periodic message within the pregnancy periods or stages as you journey along. A classic example in South Africa was a simple text messaging, where in this case, if you're thinking of teenage pregnancies, where people, it has also its stigmatization and every other thing associated with it, where then in this case, there is a number that you could easily just contact, perhaps anonymously, and then get all the necessary information. And here is where if the difference is the safe abortion versus unsafe abortion, and where the inventors or the programmers of this Cell Life project have found that unsafe abortion was also on the rise, and therefore how could they intervene to a safe abortion. And this is an example of just how they provide information to direct patients, or in this case, but the women who carry babies, that they unwanted pregnancies, and how to go through the safe abortion quest. So this is coaching women through medical abortion processes. And then later on, just to also add, just to understand the full scope of what the message is, at the end of it, when the abortion is successful and you have done the self-assessment of your abortion completion, they provide you with family planning information that you could also go through. And the way the messaging is even carved is very interesting. Say hi, more on avoiding pregnancy with a very nice smiley or emoji there. And here is because you have gone through safe abortion. And now the idea is that perhaps you don't want to go through it again, and therefore let's protect you against this unwanted pregnancies, as the case may be. Now, these are simple technologies, as we have seen. And then another project, which is the Millennium Villages GNET program. And this was an interventions under the Millennium Promise Alliance, where they were implementing some of these innovative but important interventions across what they called at the time 9 hunger zones across Africa. And Ghana and the Bonsaso cluster within the Amansia West, in some part of the Ashanti region, it was considered one of the hunger zones or very poor communities. And this cluster of communities, where sometimes they had to travel miles before they can reach the nearest health post, and therefore will suffer fatalities even on the way of journey, with deplorable states of roads and infrastructure. So this intervention was supposed to simply connect community health workers who are living within the communities to the, let's say, the district hospital, which would then have probably the full complement of a doctor and health facilities, so that they will be able to manage some simple cases and complications before they even get to the facility, the bigger hospital for it. And this was targeted at, first, avoiding unnecessary referrals, but also improving timely interventions when needed. And so this is the operationalization of the Millennium Villages Promise, which had a telemedicine approach to it, or teleconsultation approach, community-based community health workers who will usually visit the under 5 children and their mothers at home and then check their vitals. And within that particular, if they notice any danger signs, and sometimes beyond really their training capabilities or knowledge, then they will just connect to the teleconsultation center, which is usually manned with a midwife and then a nurse attending to all the teleconsultation calls that will come around. And then they were able, examples, I did one of a research evaluation on that, a fantastic experience from community health workers being able to manage postpartum hemorrhages and all that, which ordinarily they would have referred to the nearest facility, and risking losing the mothers in this case. Another health promotional activity is the BISA Hub, which simply means ask. And this one is for the population wide, the youth mainly targeted, that if you have any questions that you want to ask, particularly related to questions that, or diseases and conditions which often has stigma, like HIV/AIDS and STIs in this case. So you will chat, there is a doctor always around to provide you with information where you would be able to get your information, but often they will also refer you to a doctor when you really cannot, you need to see a doctor. An interesting thing, blood shortage, for example, can also be a very serious phenomenon in this part of also our world. And sometimes even locating where the nearest blood bank is becomes a problem. And so we have also called this Moja, which means blood. So they have a locator, simply using the GPS system to be able to plug so that we can know where the blood banks really are and where to call when there is a need for an emergency. And then they also provide it. Colleagues went to Madagascar with this Mtomadi program, and this is not necessarily for digital technologies meant for healthcare delivery, but rather for health financing. So this is digital technologies for health financing. And here they introduce what they call the mobile wallet, popularly known as the Mtomadi wallet, focusing on women to save and receive money using mobile phones, and money will only be spent on maternal health related treatment. So it is more like a fixed amount on your mobile wallet that can only be used for your health expenditure. And that's the platform that they created for that. And this intervention was actually being considered within the circles of national policy, and Madagascar was planning to form or launch or establish an insurance for the healthcare system in there. One of my last but one example I wanted to show is also a drone technology, and this is zipline drone technology, started off in Ghana and Rwanda, and then using drones to support delivery of essential medical products to the remotest communities, often rural in nature, and they supply these vital medical supplies through the drone technologies. And during COVID, it even became more essential and relevant for delivering, for example, PPEs and coronavirus test samples across all parts of the world. And then I bring in also the initiative from Medtronic's lab, which is also in Kenya, Sierra Leone, and Ghana, where they launching the Akomapa project. Akomapa simply means here a good heart, right? So it's largely NCD-based program where they were using this Medtronic technology called the SPICE app to enroll or bring about an integrated care for patients with chronic condition, so that there is continuity of care, and then ensuring that there is also improvement, adherence to medication through the follow-up mechanisms of phone calls to the patients who will sign up also to this Medtronic lab. All that I have provided is just a wide range or variety of the application of digital technologies, and summarizing them into this as we have it, from wearable devices all the way through the ones that are used for wellness, health, telehealth, remote monitoring, visualization, and clinical trials are different aspects of these technologies that we do have. And again, it has the investment of very profound companies and big companies, largely driven by established in the US, and companies like Epic and others are all investing in digital technologies. And in Africa, the 12 common applications really of health interventions are what our study found within the industry, and I give you the percentages of same here for your later study. Now, looking at all these great potentials of mobile phones and digital technologies in general in Africa, now the question is that there is definitely the need for regulatory framework for digital health technologies, and this has been really attested to by Gary Humphrey's report, where they emphasize clearly that realizing the potentials of digital health also requires overcoming its inherent risk. And particularly if you take machine learning and artificial intelligence, then clearly you know that machine learning is a major concern for medical authorities. And then we need, therefore, to ensure that the decisions and predictions that AI is also making do not cross certain ethical lines, because there are ethical standards that needs to be followed. And therefore, with the global strategy on digital health, one of the very core chapters of it, which is the chapter 3, emphasize strengthening governance for digital health at global, regional, and national level. And this, it's talking about the creation of sustainable and robust governance structures and building the capacity for digital health at global and national levels. And the objective here is that we need to, on the one hand, promote the utilization or the adoption of these ones, but we also have to promote standards for safety, security, privacy, interoperability, and the ethical use of data within and outside also the health sector. And this action to strengthen governance is very critical for digital health technologies as well. This then comes to utilizing the regulatory frameworks that exist. The question is that, are the existing regulatory frameworks enough for handling also digital technologies, which are very disruptive in nature and also by their applications? There are usually two major categories of health apps. There is the mHealth and then the what they call the lifestyle apps. I.e., if you're doing these classifications, you are thinking about medical and non-medical applications. And therefore, we can take a cue from medical device regulatory frameworks and then also model after that by developing a regulatory framework for digital health technologies. In the medical health industry or medical device industry, their classification is usually based on risk. So how invasive is this technology? And therefore, the risk criteria for classifying digital health technology, should be paid attention to in helping solving that. If you take the EU classification and their regulatory framework, they come up with software incorporated into medical hardware as like software that controls like a CT scan, will be a part of the medical device or a part of the whole program. Could we also say that if there is a digital technology and it is just the software, but it is embedded in a particular program, let's say like the SPICE, the Akumapad from the Medtronic, the software alone is not functioning, it's not necessarily the function, but rather it is embedded in a certain program of taking care of NCD patients, an integrated care program. So do we then consider the software as a holistic part or a part of really the holistic integrated care approach for NCDs? So that when we are treating or evaluating or assessing the effectiveness of SPICE, we don't single out the software, but we consider the entire integrated care program, like called the Akumapa program. And then they also have the classification of standalone software, such as the one that is used in mHealth apps, considered a medical device and falls under the scope of the EU directives, only if it has a medical purpose. So there are also the apps that are standalone, like the ones that I mentioned, like the BISA app, and then also the Cell Life app in South Africa. If these are standalone softwares, that perform their function, then the question will be, as far as their purpose of use is for medical or health reasons, then we can consider them as medical devices or health technologies, and then prescribe their appropriate technologies for them. And this is just to demonstrate the existing regulatory frameworks that currently are being relied on for digital health technologies. But the truth is that per the analysis we have done, these are not adequate. There are gaps in there that needs to be addressing, targeting the specific needs of digital health technologies. And so my last point here would be what the US FDA has taken as a step to regulate digital health technologies. That is, we are taking inspiration from in also attempting whether we could model such frameworks also for Africa. So what they do is that they created this Digital Health Innovations Action Plan, and they created what they call the Digital Health Software Pre-Certification Program. So the regulatory framework would ordinarily be where developers will sit at their own corner, have their finished product, submit the dossier to the FDA, they peruse it, and then they determine whether it is safe and it is also efficacious, or in this case, for medical devices, it is performing as the functions that it set itself to perform. But then you realize that often you have capacity issues because, well, FDA does not train, for example, IT people in there. So whilst you are beefing up your capacity, then FDA is saying that, wait a minute, why don't we rather work with the software developers? In this case, sometimes they are a team that is developing the program or the intervention that will be used for health. So whilst they are doing that, there should be a legal or an FDA regulator who is also part of the team to help develop, so that the development process is already in conformity with the ethical standards that will be adopted. And so forth, they are working to provide clarity using practical approaches that balance benefits and also risk. And this is the pre-certification program that I have spoken about. And we did a quick search and realized that based on this approach, they've been able to develop over a lot of guidelines or guidance documents with digital health content to support the development or the pre-certification processes of that. And there are over 20 reference documents that we could also explore in this regard. Now, a question, who regulates really mobile health apps? Is it the tech industry, or it's supposed to be from the health regulators? And this is a big question also in Africa. Who is regulating really the mobile technology or the digital health technology industry? And this is what my research group set itself to do for the past 3.5 years, where we are analyzing regulatory authorizations of digital technology and ascertaining the factors contributing to provider adoption and understanding the strategies for scaling up, and drawing on these lessons for scale up, the adoption and utilization of the intervention also for other African countries. Another part of it that we are doing is looking at what evidence would be required for digital applications, similar to work that we did in Germany called the DIGA exercise. I end by giving this quotation that digital health technology, which is e-health, is an emerging field in the intersection of medical informatics, public health, and business, and referring to health services and information delivered or enhanced through the internet and related technologies. This is the important point. The term characterizes not only a technical development, but it is a state of mind, a way of thinking, an attitude and a commitment of networked global thinking to improving healthcare, both locally, regionally, and worldwide using ICT. Thank you.
Thank you so much, Danny. I'm going to hand over to our third speaker, Dr. Danny. If anyone from the attendees would like to pose a question, please add in the chat. But in the meantime, I'm going to hand over to Dr. Danny. Danny, can you hear us?
1 minute, I'm having little trouble with the sharing. Is my slide visible?
Yes, we can see your slides. You can just put them in presentation mode.
Sorry, I'm in the airport and my flight, but I'm in a silent area. Yes, apologies for that. Is my slide visible?
Yes, thank you. We can see them.
Okay. So I'll try to wrap up in the next 15 minutes or so. This is a work that has started 2 years back, following which we had a recent paper with the IJPHC journal. And these are the two areas as far as digital health technologies are concerned, focusing on India. So I'll just try to focus on the clinical validation, but also the health technology assessment for digital health technologies. My presentation is in India, which is where I'm based. I'm currently Professor of Public Health in the Faculty of Life and Allied Health Sciences and the Ramya University of Applied Sciences, which is in the southern part of India, Bangalore. So India is one of the the countries where the digital health has got a lot of potential, and the overall market size is almost and I've kept it it's hovering around at the CGR at 28% in the next 6 years or so. And it also has a very overall trend where not only my apologies, there's some error there. It's not 66 or 57. We ignore that. So basically, among the Southeast Asian nations, European Union and East Asian countries, most of the accelerating innovation is actually led by India in most of these areas that are potentially there for digital health. In India, we have the government of India has promoted or presented what is called as the National Digital Health Blueprint, which is essentially to create a universal health coverage in a very efficient, accessible, inclusive, affordable, timely, as well as safe manner. And if you notice, it's not only looking at, it's got multiple building blocks. but it has got standard regulations, it has got application services, but including an institutional structure so that both the health domain and the technology can be integrated, ensuring security, confidentiality, and privacy of health-related personal information. What I'm going to look at is the clinical validation. But before I go into the topic and try to mention what is the status of clinical validation of medical AI, I thought of just speaking about a bit on what is the process of clinical validation which is being done. Is basically the process involves rigorously testing AI algorithms against very large and diverse data sets, compare their performance to standard tools, but also ensuring that the technology functions reliably across different patient populations. The main reason that we need to consider this is due to the fact that there is patient heterogeneity. So, for example, I work in a private hospital. I mean, one of the university is part, a teaching hospital and a medical hospital is part of our university. The kind of patients that might come for, say, let's say, breast cancer or oral cancer would be of a certain economic strata. And probably the ones that are going to a government hospital or to a non-profit hospital with the same disease criteria, disease requirement, such as breast cancer or oral cancer, would be of a different economic or social strata. Might progress or could present in its own. So essentially, we need to not only look at data privacy, but also look at algorithmic bias, any potential unintended consequences for essentially mitigating any risk that are associated with AI adoption. So why is this needed? That's mainly because if AI technologies, basically in India, the AI technologies are registered under the CDSO, which is a Central Drug Safety Organization. And under that, the medical AI is registered as a software as a service, SAS model. And but it is not coming under the medical devices as of now. But if you look at the overall trend in which AI technologies are being done, it's basically being looked at from a prognostic or a diagnostic or a model approaches. So any decision support that is being provided should actually be not only optimized but also personalized continuously according to the phenotype of the patient. The performance would also rely strongly on what are the kind of training data sets that are used. So that, but what happens is you need to constantly assess the performance and safety of AI before you actually introduce into the routine clinical use. If you take these considerations, AI technologies should satisfy stringent regulations for approval as similar to the medical devices. So that is the main reason in which you need to consider clinical validation. And in terms of clinical validation, where we are at present, there was a study done where they tried to compare COVID-based predictive accuracy models between a high-income country, which is in the UK, and a low-income setting in Vietnam. They noticed that without customization, if you just plug what is available as a predictive performance model for UK, it resulted in a very lowest predictive performance, and there was a very high variability in AUROC, but also sensitivity and specificity. So basically, there is some need of additional research as being indicated where model performance declined. And these are studies which have shown that while the pilot data set sensitivity specificity could be at the range of 90 to 95%, but in reality, a literature review has actually assessed that most studies did not include the recommended design features. And actually, when it gets adapted to the real world setting, such predictive values can reduce as high as 30% in the real world setting. In India, for example, there is a company which is using breast thermography or infrared imaging as a screening tool, and that has been it's a commercial company which is based out of Bangalore, and but however their technology is not supported by the Society of Breast Imaging India, mainly because they have some limited reservations in which these diagnostic tool has been validated using very small sample sizes, for example. There is no reference population. And also the paper that from which they have established the sensitivity specificity is actually 50% of the authors are from the company, so they have not declared a very explicit conflict of interest as well. So this is the slide which actually shows that if you look at all the results across, performance of AI algorithms for medical diagnosis prediction, you'll notice that the diagnostic accuracy of these AI algorithms actually decreases, or the presented probability becomes incorrect when you actually take it from internal testing to basically external testing when you put it into a real world setting. So this is where we are now. India is not very far behind. And the need that is needed is what is called as a calibration accuracy, where basically you look at using the Bayes theorem of probability, where the actual probability of detection would be greatly influenced by what is called as the pretest probability, also referred to as prevalence. So essentially, any algorithm that does not take into consideration the pretest probability is very likely to be very inaccurate, and hence a rigorous evaluation of the calibration accuracy is also required, so for all AI algorithms, so that it presents probability directly to the users. So we have one of the issues around limited generalizability, what is called as overfitting. And overfitting happens due to various reasons, but one of the main reasons for overfitting is due to the fact that there is patient heterogeneity. So you have, there's a lot of data dependency because of machine learning algorithms, such as deep learning, which is characterized by very high dimensionality and mathematical complexity. So while in training data sets, you are expected to get a very excellent accuracy, but when their performance deteriorates when external data is not used for the training data set, which essentially means that if you are using a pilot test from a single hospital and using that to develop your AI algorithm, but it is not considering multiple hospitals, then it will end up having lower accuracy. And this phenomena is actually called as overfitting. So most of the AI algorithms, including India, have got this issue around prone to overfitting. However, we have certain techniques which can reduce overfitting, which is basically called as regularization. But regularization alone is not is very insufficient, where you take regular kinds of data, but you need multiple data sets from multiple hospitals so that you can overcome patient heterogeneity. And hence, many AI algorithms actually fail to generalize when you apply it in the real world population. So these are some of the reasons. Most of it are very straightforward. Medical data is highly heterogeneous. So, for example, even if the patients have the same disease, other characteristics such as age, sex, disease severity, underlying conditions, or comorbidity may often differ across the capacity, type, and location of hospitals. The situation of one hospital often cannot be data heterogeneity, and there's also something called as the temporal heterogeneity, which basically is due to the fact that there are advances in healthcare equipment and technologies which require constant changes in therapeutic agents and diagnostic tools, for example. So now, because of this, there are certain implications. There are three implications that have been identified from public literature. First is, when you're evaluating an AI algorithm performance, it is important to perform external validation using an external data set. And instead of blindly accepting the result from an AI algorithm, medical professionals should basically take decisions due to taking due consideration to the clinical situation and other relevant information. And finally, it's as a method to improve the generalizability of AI algorithm, you might need to consider an additional training round so that from administered data from target hospitals and specific clinical settings prior to its use in the clinical practice. So this part one is basically around clinical validation. I'll try to focus on part two, which is on the digital health technology and also the HTAi component around it. Just to explain that there is, if you look at a conventional HTAi, you have, comparing a novel intervention or a technology with a standard of care, where you have a constant clinical impact which is achieved over a course of a disease from a very society perspective. But in contrast, when you consider the AI or a DHT, digital health technology HTAi, then not only you can have more than one or numerous comparators, but also because of the variable and the very unpredictable future impact and value. So where you need to consider basically the slide is trying to highlight that the conventional HTA might not be suitable or might need to be modified when you're considering HTA for digital health technology. And what is important to understand is this whole concept of exceptionalism of AI health technologies. So it has very distinct features from traditional health technologies. Their systemic impacts on healthcare and health sector are also larger. Basically, there are very high increased expectations towards AI in health, which is traditionally very high, considering a lot of these AI technologies are being focused on India. So it is being looked at a kind of a complement or to fill up the gaps in resources in terms of doctors or medical devices. So the expectations are also a little bit higher. You also have various ethical, social, legal challenges that might arise due to deploying AI in the health sector. And then finally, because of there are new evaluative constraints that AI can poses to HTS. So if you look at the key challenges as far as AI is concerned, as far as HTA is concerned, you have 6 elements. You have technological challenges, which looks at which basically about not only the aspect that I just mentioned in terms of the validation, in terms of the technical validation using appropriate data set. It is also about the clinical validation, which requires reference data sets. For example, you also need to consider the human and the cognitive element in terms of, is it acceptable by the patient? Is the clinician willing to integrate it as part of the clinical care? There are, of course, professional and organizational challenges on how to integrate AI, medical AI or digital HTA, digital technologies as part of care delivery. And of course, there is this whole economic and legal and ethical dimensions which are considered as challenges for AI for HTA. So when we looked at, as part of our work on the digital age technology, we found that yes, there are these country-specific HTA guidelines for digital age technologies, and that includes South Korea, France, Germany, as well as United Kingdom. But we found in detail that there is a DHTA, which is a criteria tool for assessing digital health services in Finland, and it includes all the key elements, such as effectiveness, cost, usability, and safety. And based on this criteria, experts who are conducting HTA can give recommendations on how suitable different products are for use in healthcare. And the recommendations are based for supporting health policy and clinical decision making, similar to any other HTA exercise that is being done for conventional devices or drugs or vaccines for that matter. But the advantage of digital HTA, DGHTA for Finland is also that if there are product developers or manufacturers, while they are developing the product development or self-assessment, they can use the criteria to assess how the steps have to be conducted as part of the development process. So these are the domains in which the DGHTA functions, that the DGHTA requires company information, product information, stability, cost, effectiveness, etc. But it also looks at including whether it's a specific artificial intelligence, but if it includes robotics, then we need to include that as well. Now, based on this work is what we did for a recent paper that's currently online, which is basically looking at digital health technologies in India. And based on that, what we did is we initially did a search to understand what are the frameworks around digital health technology, and that's the result that I just presented a couple of slides back. And then from there, we actually reached out to almost 20 specialists in India with diverse knowledge in digital health technology, HTA, clinical and research. We contacted them through email, and they were given 2 to 3 weeks to respond. And then based on the input, we used the qualitative research and using a grounded theory approaches. My colleague Rakesh did that work. And then finally, we used the model framework to construct the appropriate themes and domains. And finally, using the specialists, we could develop a DHT framework in India. So there are some of the results and lessons learned are basically that many participants have varied understanding of what DHT is. They assume that it's comprising right from digital HR and EMR were the major understanding of what digital health technology would be based on that. So it could include EMR, it could include automated reminders. So they did suggest a framework if possible. and identifying specific healthcare challenges or opportunities was the major reason. And one of the important factors that they did mention that they're selecting an appropriate comparator or control group is very crucial for the DHT framework, and also include behavioral theories for basically assessing the digital health technology. So one of the conclusions that we could do that, of course, the understanding of digital health technology encompasses from these 20 experts was a very broad spectrum. And there is a necessity for looking at a DHT health technology framework for India to ensure that there is evaluation of these digital health products. But you also need to ensure that while usability and accessibility domain were the most significant areas suggested for improvement, due to the LMIC nature of India, there was inclusivity also as part of it. And of course, like any other country, there is need for political determination and financial resources. But since we know in economics, money follows the patient. So if health insurance agencies and hospitals would be needed to play a greater role for the effective execution of digital HTAi in India. So thank you. That's it from my side.
Thank you so much, Jani. Thank you so much for the insightful information. Thank you to all of the speakers. I'm aware we are slightly a bit over time, but I'd love to thank everyone who came to attend our session, and I do hope that you found it insightful. And please, if you can, check out the HTAi DCIG interest group website and join if you can. Thank you so much once again. Thank you to the speakers for your time.